demonstration will be done by ma'am. I will take you to the OT for that.
Hello, madam.
Hello.
Yeah.
Good afternoon, everybody. At the onset, I would like to thank the entire team of KPCON to have me here to share my experience. And I also would like to thank Dr. KP Morwani to keep the spirit on as far as all the students are concerned. Because when he trains one student, each student of him treats number of patients. So all his expertise is disseminating to the patient's welfare. To start with, this is a patient with mainly unilateral complaint, but if you go and see the CT scan, I'm going to quickly go through the CT scan because patient is already under anesthesia for quite some time. If you start with this cut, you can see that bilaterally the frontals are involved. And as you go further, you can see that there is a mild DNS here.
Yes.
Which may require little correction when I'm doing the right side of frontal. If you see that the entire osteometal complex and the area of frontal sinus is involved. In fact, you can see that there is a communication between the two frontals when you go a little backwards. If you see here, you can see that the uncinate process is almost dissolved. And you can see the maxillary sinuses involved, almost it is attenuated. You see that the frontal nasal recess area is also widened because the septae within are very much thin and flimsy. If you go down, you can see very carefully, you can see that the uncinate is attached to the lamina papricia. So you will see something like a terminal recess. We actually did not have a DICOM images of this patient, otherwise we would have taken you frame wise. The entire middle meatus is filled up, but what I see post steroid preparation, that a lot of disease has been cleared. If you go backwards, you can see that here you have a frontonasal area which is affected. You have almost Keros type 2 olfactory fossa. You have double density, so we may get suppurated fungus with us, but it's not very, very obvious. As you go backwards, you see some area of air in the maxillary sinus. So we know that it's partially ventilated. And you can see here the beak. In this cut, you can see the anti-ethmoidal artery, which is forming the roof of the ethmoid. As you go backwards, you can see that the entire left side is involved. As you go further, even the posterior ethmoids are involved. Some area of sphenoid, and you have probably a situation like onodi. But posterior cells are still free. And if you go still backwards, the sphenoid is nearly free. So without much discussion, we will go and start the case. इधर रखा है. In the meanwhile, when I was waiting, I've already infiltrated.
In the pre-op, you will give.
Sorry?
In
Ballpoint. I didn't get your question, sir.
Madam, anything in the pre-operative, you will prepare the patient few days prior to surgery?
Every patient which is scheduled for surgery, we always give a good course of antibiotic and steroids. I start preparation minimum 2 weeks prior, so that when we are operating, we have a good field and inflammation is taken care of. Here you are seeing that the unsynapse process is almost polypoidal, but which is the polypoidal part of the unsynapse is resolved dramatically after the course of steroids. But as I told you, if you go to the middle meatus, you can see that some area of superficial fungus is there.
Yes,
so this is where we saw the double density sign. The maxilla, as I told you, it's partially ventilated. So after the course of steroid, all this area which was completely filled up is quite cleared. Presence of AFS doesn't allow all the disease to resolve. So these are the definitely indications for surgery. Pause, please, Anna, please. So however you give steroid, patient will become fine, but it will not be resolved completely due to presence of this superficial fungal disease. You are seeing here the middle meatus. There is some deviated nasal septum and bulge, but I think I'll be able to manage with decongestion and all. I've got good space here. If you see here in the upper area, frontoethymal recess, we have polypedal tissue. So and if you see here, this is the free edge of the uncinate. And if I try to fold it backwards, so what I'm trying to do is I'm going to use the backward biting forceps, that is ostrums, to do my first cut.
Standard.
But you have a very large uncinate here.
Hello.
I've almost unfolded the uncinate. So whenever without doing the uncinectomy, you see it's more of a accessory ostium. So I've taken one bite, and if you go backwards, we are already seeing into the maxillary ostium.
Hello.
Yes.
Hital Prasad here. Can you
Hi,
change
Prasad.
it to Clara or a standard mode? Because it's little red picture here.
Sorry?
The picture is little red. If you change it to Clara or a standard mode,
I will.
yeah. Thank you.
You feel it's very red.
Yeah.
Are you changing, or should I do it from up? Yeah, I'll try. I don't know where you have. Yeah. So I'll go to.
Either Clara or a standard.
Yeah. Just see whether the picture at your end is improving or not. Just let me know. Are you a little better?
Little better. Can you change it to standard one?
Let me try.
Okay. Yeah.
Is it better?
Yeah.
Because for me on the screen, it's very good. It's
Yeah.
the color of the projection,
Yeah,
basically.
maybe.
Because always you get very good picture if you use both Clarachroma, especially when there is a bleeding. So once you have taken your first bite, you can use the debrider and the upper part of the uncinate and the polypedal part of the uncinate. I would like to remove it with the debrider. As we know that when you are doing a standard face, you have only 4 important steps. One of the first step, it is the uncinectomy. Though it is the first step towards the endoscopic sinus surgery, it is one of the most important steps, because if you remove the lower part of the uncinate well, you will get a good entry into the maxilla. This I'm trying and removing the upper part. Because of the chronic sinusitis and long standing, you can see the upper part of the uncinate coming out. You can see the bony part. Can I have a upward blacus, please?
Hello.
Yeah, you are already
Dr.
seeing into
Sanjay
the.
Hilali here.
Yes, Dr. Sanjay Lale. Good morning.
What was the packing solution?
Yeah, my petty solution which I had used was 4% lignocaine with adrenaline, 4 ampule of adrenaline.
So 4% 30 ml and 4 ampule adrenaline.
Yeah. So here what you are seeing is the lower part of the horizontal part of the uncinate. Still, I have some part of the uncinate remaining. Patty there. Patty. So this is again a small piece of merocell with 4% lignocaine with adrenaline. It acts as an excellent tamponade as well as it causes good amount of decongestion and doesn't allow a lot of raw area to be created.
Madam, would you please rotate the camera a bit? Yeah, thank
Yeah.
you.
Can I get the ostrum again, please? So we need to remove the horizontal part of the uncinate also. It is very thick because probably there's a long-standing disease. And I'm using, you can see the ostrum because I was not able to break it through the ball point. So you can see the horizontal part of the uncinate is removed. Ostrum. I still have a small remnant of the uncinate at the lower end. The driver, please. Now what we are going to do is, I'm going to use the standard technique. So a lot of the bulla, I'm going to try and, this is the anterior face of the bulla, which is almost opened up. Just thoda irrigation karna, so this is the upper limit. Here, if you see the bulla is going right up to the upper level. I have very little suprabullar recess. Else I would have demonstrated you the intact bulla technique also. But here you can see that the bulla is going right till the upper level. There is very little suprabullar recess.
All right.
You can approach the frontal in different ways. So I was thinking that we would have probably tried and show the suprabullar approach, but very little suprabullar space doesn't allow you to
Enter the frontal sinus.
yeah. Can you see it? Can I make it little better focus? Better? Ball pen, you know. So once you have, you can see here that this is reaching, we saw it in the CT scan, it's attaching to the lamina papricea. So this is forming like a suprabul terminal recess, which is also diseased. Yes. So we'll clear this area. This is the lateral attachment of the bulla. Suction is not working properly. . The disease has already traversed me to the posterior ethmoid. So once, WhatsApp Jana, please. So presence of infection doesn't allow you to get a very good feel. You can see here that the entire mucosa is bleeding. You can see the superficial fungus coming out in the suction.
Madam, what are the landmarks you are following at this moment?
Right now, I've followed the disease at the moment, and I have cleared the anterior ethmoid and gone right till the lateral limit.
Yeah.
Still on the upper side, on the superiorly, the disease is, unless we clear a little bit of disease, we will not get the landmark. So I'm really debulking the disease.
Yeah.
Give me a Merocel, please. That 4%. Now to clear the upper part, I'm going to switch to red 70-degree telescope so that you can see the frontal area cleared very well.
Yes.
I'm just going to put a piece of Merocel with 4% lignocaine with adrenaline so that to get a little better visualization for you. Yeah, I'll switch to 70 degrees because now we should clear the disease. Section number 70. Can I have the angle suction also? Double go. Usually the best case to demonstrate the surgery is a case of sinusitis where the landmarks are all preserved. Here, because of the presence of polyposis, which is also quite significantly reduced after the course of steroid, the landmarks are lost. As you saw that in the scan also, you were not able to see the bony landmarks.
Yes, ma'am.
Because there was almost everything was white out. Give one more patty. Direct adrenal patty देना सर. Direct नहीं Merocel में ही डाल के दे दो. Direct adrenal. Just remove this. Remove this. Just going to put a little concentrated adrenaline patty so that you all can visualize it better. $70. Just switching to 70-degree telescope, you can also switch to 45-degree telescope. But if you want to do the instrumentation with 70-degree scope, 45-degree, it becomes little limited. Please give Rad 60 blade, please. So here you are seeing the upper part of the uncinate. Upper forceps, please. Ball point. This is the attachment of the uncinate and this is the terminal recess.
Yes.
So this is your upper part of the uncinate I'm removing.
Uncapping the egg.
Yes. So you can see that coming out. Upper forceps. I don't have MP4 handpiece, so I need to remove the bone by myself. If you have a M5 handpiece, then you can remove this bony part also in it without it getting blocked because it is good enough to take care of the tiny bony spicules. Now, when you want to go to the look for the frontal, you have to go stepwise. You have to see that which cell is leading to it. This still is not the the medialmost cell is the one which is leading to the frontal sinus. Upward curate dena, please. I can easily go with the debrider and clear it, but I would like all of you to see it. So this is the cell which is going to lead me to the frontal sinus. So we need to clear these cells. I will take the debrider and remove it. So widen this and go towards the medial aspect which is leading to the frontal sinus. I'm using 70-degree telescope and red 60 blade. To clear the disease in this area. And you can see the AFS. Can you see the fungal?
Yes.
Yeah. And I've already entered the frontal sinus.
You can see the frontal
Yes.
sinus. Yes, madam.
This frontal is also communicating at some level to the opposite side of the frontal. And that is how, though there is not much disease which is seen in the nasal cavity, the opposite frontal is already involved.
Yes.
So you can see the illuminated frontal sinus. Here, those who are in the OT can see, but we still can remove this part of the disease. Okay. Please clean the tray. Are you seeing it? Are you seeing it? And as I had discussed while discussing the scan, that's a Keros type 2. So one has to be very careful when you are dealing here. Okay?
Yes.
Yeah.
Because you have a very deep olfactory fossa. And this will be somewhere the area of anterior ethmoidal artery.
Yes.
As per the scan, it is almost not surrounded by the bone everywhere. Can I have the bipolar cautery, please? Here's the bipolar switch. Okay, it's there on the left side. So there is little bleeding. Whenever you have little bleeding in the area of anterior ethmoidal artery, you make sure that you use only the bipolar. Just clean the tip, please. And with little irrigation. Can I have the bipolar again, please? And it's never the whole bleeder. It's always a puncture mark on the anterior ethmoid, which can give you the bleeding. And one must do this under irrigation so that so one of the most important thing that whenever you are while doing endoscopic sinus surgery, if you are bleeding, then in the region of anterior ethmoid or posterior ethmoid, yeah, 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 yeah.
Yes.
There is one cell above that. Yeah. Divider block हो जाता है. Upward दे. Upward forceps देना please. Just your हाथ डिब्राइडर देना. Sorry? Yeah.
This is now, madam, first fovea, right?
Sorry?
This is the first cell behind the frontal, and then you will get.
Yes.
Yeah. Yes.
Can you see the cell?
Yes.
Yeah.
And posteriorly, I will have the anti-ethmoid.
Yes.
Can I get the forceps, please? It's very important to remove all these bony spicules. Otherwise, they'll cause osteitis in your operated cavity. Can I get one more piece of Merocell with adrenaline? Now you can see the anti-ethmoidal artery.
Yes. Yes, madam.
It is at point exposed and which was seen on the CT scan.
It is not in a mesentery, almost adjacent to the skull base.
Yeah. Look here, it is almost not, it is almost exposed.
Yeah.
That's why I was going a little slow, but I have a master behind me, my navigation system. So Satish was standing behind and said, Nikal de. So my navigation was there behind. Little hazy picture. Let us clean the tip. इसे थोड़ा सा लाइन डालेंगे इधर सेवलॉन के अंदर बहुत कॉन्सेंट्रेटेड है सेक्शन देना दब upward curve. I usually what I like to use the upward curve suction, so it directly just goes. You can see now. Can you see the appreciate the loose anti-ethmoidal artery?
Yes.
Okay, and you are seeing beautifully the frontal sinus. You have little AFS, so later on I'll just give a wash and make sure. See within the frontal sinus, you can see
The debris.
Yeah, so we'll clear that. We'll clear that also.
Will you
So
see
one of
inside
the
the
very
maxillary sinus, ma'am, since you are on?
See now, once I'm seeing the frontal, you rotate the light cable to 90 degree, and you can see the whole of the maxilla.
Maxillary sinus, yeah.
Yes.
Okay, so I'm rotating, but I need to clear all that disease because. So again, when I'm with the 70 degree scope and I'm clearing this area of the maxillary sinus, I'm
Yes.
in the maxilla. So in the scan, the maxilla looks very much diseased, but you saw that the little polyp which was there, which had shrunken,
Yeah.
I removed it,
Medical polypectomy.
and it was a yes. So a lot of medical disease or medical management of the polyposis had taken place. And that's why disease is far less than what it was there in the scan. Usually post-operatively, what you need is just a 3 millimeter of opening for draining of the maxillary sinus. So I don't like to really widen the maxilla all around because we don't have much disease in or around or beyond the maxillary sinus.
Yeah.
So there is no need to do a very wide opening.
Do you believe in nitrous oxide theory?
It is always important because they say that the circulation of production of the nitrous oxide gets affected when you do a very large enterostomy.
Yeah.
You don't need it. See, if I had a disease within the maxilla or I had to go beyond maxilla, or if I was doing angiofibroma, yes, I would do a very wide opening.
Mhm.
Now I'm going to switch, give me a Merocell with
zero?
adrenaline. I'm going to switch it to 0 degree scope. because I still need to clear the posterior ethmoid cells. You can see within the maxilla.
Yeah, it's very
Okay.
clean, healthy.
Yeah. You can also see beautifully the infraorbital now. I'll just show you one more time. You can see the bulge of infraorbital now.
Yes.
Okay. So this is a clear maxillary sinus. That little polyp which was there, we have already debrided. Just put a little 4% and I'll switch my scope to 0 degree. बेटा अपना सेक्शन है ना ये अपना नहीं है
ड्रेन होणार नाही ते.
ते होईल पण इथून वॉश लागेल ना
हा.
स्पीड नाही त्याच्यामध्ये
So now what we need to go is go towards the clear the posterior ethmoid completely and go to the sphenoid. Though on the scan there is not much disease in the sphenoid.
फंगस निघाला की प्रश्न you give steroid, it will all going to go.
Even like this. Even like this.
If there is a fungus, this is all going to go. If there is no fungus, it's all going to be stored.
Always go inferiorly and medially, and you can see I have already entered the sphenoid.
If you do the fungus, there are chances that
Provided you keep even that dot of fungus, no, it will recover. You keep a single dot of fungus.
Straight through cut.
Most operative.
I never like to go in the sphenoid and work with the debrider. You should always work outside the sphenoid ostium. You're already seeing the landmarks section,
Yes.
then please. You
Sphenoid
can
is
see the
pushed
Onodi
down
cell.
So inflammation.
because of onodi, sphenoid is pushed down.
Yes. You are already seeing the optic now.
Sphenoid.
This is the optic now,
Onodi is
laterally.
another-
I need to clear this disease, which on the while discussing the scan, we had already talked about that there is probably a situation of onodi. Straight forceps, please.
Stay over.
Take them back.
Stay over. Stay over.
Give me the regular so that I can remove the
Let's forget it.
polyp, bony spicules.
lateral is it. That is not anterior posterior cell.
No, this is not onodi. Onodi must be above and lateral.
No, no. This is here is a sphenoid.
Oh,
Yes.
This is a part of onodi only.
that is the one.
Hmm.
This
I
the
agree.
better. So now you can see it's connected to the sphenoid. Section, please.
आपण आपण उलट होतो.
Can I have a downward section?
मला कसं तरी आलं, म्हणून मी निघून गेलो. You should tell them.
सांगितलं सरांनी.
सांगितलं?
आपण
नको वाटतंय. किंवा maybe what she does,
Upward forceps, please.
doing it like this.
Small upward forceps.
हा, यार.
And a punch also. Hey, don't cross me, beta. Punch, please. Let us remove all that bone edges.
Madam, in post-operative, what all things you will give to this patient?
All
Medication.
patients post-operatively, apart from the nasal douche, antibiotic for a period of 1 week, steroids for a period of a week, 10 days, because the mucosa will take time for it to heal, and later on it can be given under nasal spray. I always like to give patient nasal douche unless I have a lamina dehiscence or if there is a erosion of the base skull or something. Otherwise, most all patients I like to give them the nasal douche.
How long?
So that at least 6 weeks. Sometimes patients complain of headache following the wash. That means they are not doing the wash properly. In those patients, I may stop little early. Section, please. All this disease has to come out straight debrider. But once you know the landmarks, then you can very easily remove the polypoidal tissue. Punch, please. You must remove all the bony spicules because otherwise it causes osteitis and doesn't allow the area to heal well.
Heller cell.
Debrider, please. Yeah, there is one. It's a Heller cell. The tiny Heller cell.
Madam, camera is rotated.
It's little loose, you know. So it is not getting locked very well. So the disease in this region can cause inflammation and make the maxilla to get blocked. Yeah, I've cleared the Heller cell. Upper fossa. I always like to keep this lower part of the bulla because it keeps the turbinate by itself away from the lateral wall. And if for some reason, if this area is diseased, then I may remove this and do a vulgarization using I usually like to take a stitch there to make sure that my turbinate remains away from the middle meatus area, or rather it is medialized. So whenever you try and remove this disease, it can become unstable, but in a case where there is AFS, I like to open each and every cell. Otherwise, you may leave behind some AFS here. Section, please. Can I have straight section? So you are beautifully seeing the optic now. This is the clivus region. This is the optic now. This is the carotico-optic recess. This is the siphon of carotid. You have some intrasphenoid septae, and this is the region of clivus. How much time is there? Upward. The other case is ready? Upward. To show you all the landmarks, this is the anti-eighth model artery. I have a little disease which is going behind, which also I'll try and clear it. This is the polypedal mucosa of the frontonasal recess. We don't want to create any raw area here. Sometimes you have more than one twig. Chota upward, you know, baby upward. This is the area of the posterior eighth model artery. And this is the optic nerve. This is also a disease cell which I will remove it. I will not use a debrider because I'm very, very close to the optic nerve. But gently I'll remove the disease from here. Okay. This is the pneumatized antiaclinoid.
Yeah, no matter.
We need to give a wash to the frontal because there is a AFS in the frontal. So can I please get the upward suction and 70-degree scope? So that little AFS which was there, I will just give a wash and make sure it comes out of the frontal sinus.
Will you check the stability of middle turbinate, ma'am, once again?
Sure, I will, once I change the scope, I will.
Yeah.
So this is the disease in the frontal.
This is a cell.
No, 90-degree hai?
This one?
90-degree. 90-degree section is there?
On the posterior border of the frontal sinus. There is always one cell behind.
The 90-degree section.
आता जो frontal peak थोड़ी काढ़ा
Give me double curve section. Flush.
हे बघा फ्रंटल सायनस आहे.
आहे ना अजून दोन असेल असं.
कुठे असेल तिथंच वेसल आहे.
This is anterior third only. You can go behind the anterior third and see.
येणार नाही तिथं, हे बघा.
Mucosa असेल तर त्याच्या मागे स्पेस नसतो.
सक्शन दे त्याला सलाईन घाल. नाही नाही सक्शनला तेच ठेव. Give me this upward. Just put it upward.
How it will form a posterior border of the frontal vessel.
This is falling short, so we need something which goes upward.
विचारा.
If there's a 90-degree section, na, it was very good. Give me the double curve. Double curve के ऊपर section दे. Line दे. Double curve पे.
ठीक है.
Hello.
Yeah.
Shital, I just want to know, is that anterolateral artery what you are touching?
Yeah. It's a dehiscent anti-eighth model artery without it's in the mesentery.
But it's.
I showed you on the scan also that it is without the cover.
Yeah, this is anterior third only. Yeah.
Yeah.
Look,
It is.
I showed you on the scan only that probably it's without the cover.
Yeah.
But I had only one cut there, so I've
But,
taken a double curve section to take out the, just put the whole, cover the
But
whole.
ideally, anatomically, there should be one cell behind the frontal recess and then you get an artery. In this case, it is directly along the posterior border of the frontal recess.
It is not always, if it's a type 1 frontal only, then you will get it like that. You will get one cell and then get the anti-eighth model artery. There was a cell, see, I had broken this.
Okay.
There was a cell.
Okay, there was a cell.
In fact, I told you that Satish told me to remove it.
Yeah.
I am not able to reach there
Wash.
very easily. I gave wash also. If I had a 90-degree suction, I can easily reach there. They don't have. Hole band kar, hole band. इकडचा hole band. Yeah, I think now it has come out. Still it has not come out. Can I get red 60 blade? Just give it with a suction.
But the
Now the frontal is wide enough, it will drain off, but if I can remove it, I'll be very happy.
Do you have articulated punch there, ma'am? You can remove a
Sorry?
bit of articulated punch, can take out the frontal beak a little.
Yeah, yeah.
Hmm.
Can I have the debrider? I also want to remove this tag. So again, I'm using the angle blade.
Madam Shashikant here. Hello.
Sorry.
Madam Shashikant here. Sometimes
Bol, Shashi.
the intensity which goes till that frontal sinus and you can suck it out of the flesh because it is quite malleable.
I can't get you. Your voice comes very cracked. Double curve section, dena. Double curve curate dena. I'm not able to reach there. Frontal forcep आहे का?
Madam, malleable suction नाही त्यांच्याकडे. Malleable suction.
It is
तुम्ही
falling
वापरता ना?
short there. If I had a 90-degree suction also, no, it will come. But this is not, I don't have a 90-degree suction here. It will flush it and come. Giraffe force दे दो. Let me see if I can. This will not reach, beta. Giraffe, frontal.
Testing करताना कधी-कधी उडायची. What tries both the ends.
I will try if giraffe reaches to remove that secretion. It is upward and it's in the one of the crevices. Anyway, हाँ वॉश दिया मैंने उधर नहीं पहुंच रहा है.
Very strong.
4-5 times I give. Give me a suction, oxygen.
Madam,
Catheter.
if you have a malleable suction can reach there and flush it strongly, it will come out.
Can I have a small catheter which can go into this infant feeding tube there?
आपण ते जाऊ शकतो.
Double curve curate there.
Madam, hydrodebater would have worked.
Now something has reached. Is it touching?
Hydrodebater पाहिजे. 120 debater.
हाँ. Sure. What I'm planning, I'm just arranging for a oxygen catheter, which I'll put it through my double curve section and remove it.
Okay.
Now to show here the right side nasal cavity, 0 degree, please. I have a very large agar nasal cell here, and as you know that agar can be one of the reason which can block the frontal. So here you can see the.
On the right side.
Yeah, I'm on the right side. I've already infiltrated when I was waiting for you people at the time of the inauguration. So here you can see that there is a middle turbinate. There's little DNS here, but there's a large agar nasal cell. So what I'm going to do is, there I showed you with the uncinectomy using the Ostron's forceps. Now I'll show you with the sickle knife. Give me a sickle, please. And here you will have to concentrate on to removing the agar nasal cell also. So you'll have to bear. I'm just going to do a little bit of jugglery to avoid doing the septum. If the need be, when you people are switching to other case, I will do at the end of it. Yeah. So I'm using it like a saw-like. And you can see it's coming in 3 layers. You have a mucosa, bone, and mucosa. And you are seeing the. So whenever you are doing with the sickle knife, you can use the blackest leaf forceps to remove the upper part. And in a right nasal cavity, you will go anti-clockwise on the upper part. And in the lower part, you will go clockwise to remove the uncinate. And you can see the whole uncinate process coming out. Debrada, please. Forceps, please. Small part of the upper part of the uncinate has remained because it broke in between. Okay, so here what I have done is just remove the uncinate. You are seeing a large bulla. And this is the upper part of the uncinate, which forms the terminal recess. Can I get the upper forceps? If they can inflate the cuff, no, my fogging will decrease. There is some air leak. So what you are seeing is the upper part of the uncinate. So this is the terminal recess area I am removing with my upward forceps. I'll try and show you the intact bulla technique in this, because there's hardly any disease in the bulla upward section. Okay, you're seeing the bulla. Who's at the mic on the other end? 70 scope. Dr. Helale?
Yes, ma'am.
Upper.
Yes.
So I'll try and show upward. Just give me one Merocell with adrenaline and switch my 70-degree scope and double curve section.
I don't know. How it is. I don't know.
So I'll just switch to 70-degree and curved section to show you the frontal by using the intact bulla technique. As there is not much disease in the bulla, we can do that.
Yes.
Here the landmarks are preserved because of the limited disease.
No.
So this is lower part is the bulla, chota, smaller one. And a curate, please. Double curve curate.
Is this agar nasal cell?
Posterior part of the agar nasal cell. This is
Yeah.
the posterior part of the agar nasal cell. Debrada, please. So we'll clear this little bit of remnant of the
Agar. Uncinate.
uncinate first, and then I can see the posterior part of the agar nasal as a eggshell. Ball point, please. Ball point, nahi. Double curve section. Double curve curate. So you remove this cell.
Yeah, posterior wall of agar.
Yes. What I've removed is the posterior wall of agar. And because of the little deviation, which if I would have corrected, it was very easy to demonstrate. Upward forceps. If there's an MP4 and handpiece now, then it can take away all the bone also. Section. I'm just seeing a glimpse of it. Can you see the frontal? But I have to clear everything which is there in front. Red 40 देंगे ना तो शायद they will be able to see better. Gauze piece, please. So clean then, na. I want to clean the scope. You can see the almost I'm reaching. Upper forceps, baby then up now. Very small upward is there. Please give me my forceps.
Yeah, that's the frontal sinus only.
Yeah. So give me a marrow cell with adrenaline, pure adrenaline.
एक फोटो घ्यायला सांगू. त्या मुलींना सांगूया ना. Sir,
Section. Double curve section. So what you are seeing here is with the intact bulla, you are seeing the frontal being opened.
त्याने काढला सर फोटो तुम्हाला पाठवतो सर.
Can you see that?
yes. Yes.
I just need the debrider to remove this cell also. Sorry.
माईक बरोबरच घ्यायचा होता ना. नाही ह्याची क्लॅरिटी वेगळी आहे. क्लॅरा आहे. हा क्लॅरा.
Can you see?
Yeah, yes, ma'am.
Section. So we have opened up the frontal here. Upper forceps. I want baby upper. I want to remove this bone. So say 70 or 45 है? 70. Section देना. I'm falling little short. Maybe because of the deviated septum, I don't have good space, but otherwise frontal has been opened up. Okay, as you have seen that this side frontal is very small.
कोणतं?
ते बरं आहे ना?
आपल्या बॅटरी दिवसभर
क्या?
ते करायला.
No, I
So
feel
that
that
one is
I've
the
still
frontal
not
only.
opened on
He
this
is like
side.
that. Yes. Yeah. सिटी स्कॅनर छोटच आहे.
Mirror cell just देना.
हा दाखवलं ना.
No, a lot of
छोटं होतं right side.
adrenaline देना. Just adrenaline मेरा. Packing for the please. I can't see.
There was an interfrontal connection. Madam, what is the concentration of adrenaline you are using for hemostasis here?
Here I've used 4% of adrenaline.
Hmm.
4
4 ampoules in 4%.
4 ampule in 1 vial of that is 30 ml.
Yeah. So that becomes 8.5 concentration.
Yeah. Upper punch देना. Double cup Furet दे पहले. Punch भी देना एक second. नहीं. I don't want that.
Yeah.
This is a little bit of bony spicule I'm going to remove. The remnant here. Yeah. 45 degree देना मांगता है. Yeah. Upper.
इसे पॉली
Red 60 plate तैयार रखना.
हाँ. ते शेल आहे त्याच्या खाली आहे.
Section there.
Madam,
Double cup.
Madam, this looks like a T3 shell.
Yes.
Hmm.
It looks like that. But I think there is one more partition there.
Frontal side.
Because I'm seeing some disease at the end of it. Or I'll just give a wash and see it. Because again here I have a Keros upper person. Small baby.
That is T3.
Yeah. Section. Upper. I don't think I've opened up as yet frontal. Do you think so? Double cup Curate देना. वो इतना छोटा ही है frontal. Can I have a wash, please?
It is the
I can see the transformation up now.
That is communicated somewhere. I will open up. I'm not very sure.
So we'll give a small wash to this area and almost we are done there. छोटा दे रहे जगह ही नहीं है. Fine one. Please give a fine.
तेरे पास मैं खाली ऑडिटोरियम में बोल दो ना खाना रेडी है. If anyone wants to go out for food and they can bring their plates inside also. That's allowed. Oh, allowed. Oh, नक्की नाही.
Okay, now you can see the cleared frontal sinus.
For the delegate, the food is ready, lunch is ready. You can get the food and sit in the auditorium.
निकालो हुआ. Well, so edematous mucosa only. It's opened up. No instrument reaches there. Frontal, ये देना वापस एक बार. Giraffe.
नहीं 70 तक तो प्रॉब्लम है ना. Visualization is good, but instrumentation is difficult.
Sorry.
70 visualization is good, but instrumentation is difficult, no?
No, I am able to do the instrumentation also, but my instruments are not reaching there
Okay, okay.
because the sinus is opened up, but you can see a wide opening now of the frontal. I wanted to remove the diseased mucosa, nothing else. Giraffe again. So if we can remove, because I just want to make sure that there is no AFS there. This area. No, anyway, it is becoming a raw area, so let it be. There's always, you can see that there's a cobblestone appearance of the mucosa of the frontal sinus, and on aeration it's going to become better. Now coming to, we have got that oxygen gather. ले लो.
हाँ, ठीक है.
We
Conference
have
में
got
है.
now. एक minute, बाजू. Same clean. We have got now oxygen catheter, बड़ा वाला section है. Double curve section. ये नहीं है. समझा था. मेरा double curve किधर है बड़ा वाला?
तो वो फ्लश मारने के बाद
ना. It will go here. And now flush this. So what we have done is we have taken the curved section and I have put a oxygen catheter through that.
Right.
That sinus. Just थोड़ा remove कर, slightly remove कर. Remove. पूरा अंदर ले ले बस. So now I'm introducing it. Push it. Push the catheter. Put and flush it now. इसका opening किधर है? नहीं है ना? चलो करो. जोर से. Mission successful.
Yes, thank you so much.
Okay?
Yeah, excellent.
अभी है एक जगह पे, अभी भी है एक जगह पे. चलो, we'll go exactly there. Withdraw this. Then you'll have to push it, huh? 90 degree मांगता है. Till done. Push it. Flush जोर से.
Hital,
Yeah.
if you don't mind, we'll start the other case. Moment you get
Definitely.
this fungus out, na, that you tell us, we'll come back to your frame. Okay?
No, sir. You can go ahead and start.
No, we are
I'll
going
manage
ahead,
that.
but we want to see that fungus, all of them are interested saying, we'll put you on the screen for a minute to show that. Okay?
Sure, sir. नहीं 90.
kindly shift to the other OD. Transmission. Audio visual.
Yes. Audio visual, please give the mic to the next. I think next is KPs, if I'm not wrong. Madhuri is doing.
I would like to invite Narendra Sharma sir to felicitate Prashant Kevre sir and Sanjay Hilare sir. Narendra Sharma, sir.
जरा से लिए मर रहे हैं तो इसके लिए मैं सक्शन मांगता है 90 डिग्री वाला क्यूरेट दिया डबल को कुछ तो आया है ना
उसको टच
Thank you so much, sir. Our next case is a right exploratory tympanotomy, for which the moderators would be Dr. Pilu Hakim ma'am and Dr. Sanjeev Pethe.
और क्या लगे
Next case would be done by Dr. Madhuri Mehta
अरे
ma'am.
अपना 90 ले
The
लेना
case is a 48-year-old male who has bilateral progressive hearing loss since 15 years. He's been operated with for the left ear stepidotomy with piston fixation in May 22 at BDBA, and there's improvement in the symptoms. His tunic fork test shows Rini bilaterally negative and Weber's to right. This is his PTA, which shows right moderately severe conductive hearing loss and left mild to moderate severe conductive hearing loss.
arteries पूरा खुल
Impedance audiometry shows right A type and left AS type of curve with bilaterally absent reflexes.
क्या करूं बोल
HRCT temporal bone of right side is normal, whereas left side has post-epidotomy status. Ma'am will take us through the radiological findings and the procedure.
इधर इतना से नहीं निकल रहा है क्या करूं बोल
अभी इधर से वो फिर से वो
90 डिग्री लूं मिलिंद वाला
ऑक्सीजन कैथेटर से थोड़ा बड़ा
ये देना इससे डालू क्या ऑक्सीजन लेके जाऊं दे मुझे पकड़ने के लिए
They've not shifted it yet.
काय पकड़ू यार
Take that out.
Hello, good afternoon, doctors. This is an announcement from Wallace Pharmaceuticals.
एक
Sir,
मिनट
in
भाई।
our stall, for the success of KPCON, we are distributing the prasad of Siddhi Vinayak. So we are requesting to visit our stall and collect the Mahaprasad of Siddhi Vinayak. Thank you.
Hello, OT, can you hear us?
Yes, we can hear you.
Yeah, hi. Thank you, ma'am.
But we are still on the other, the screen is of the old, yes.
Ma'am, we are moving to a second OT, ma'am. It's okay?
Yeah, yeah.
Yeah. Arvind, just move to a second OT and on the mic.
I think, oh. Okay.
बट ये बहुत थोड़ा
इससे जरा लंबा मांगता है बस it will touch
Is someone going to show us the audiogram?
Arvind, just switch to ma'am's OT. Meanwhile, yeah, done. Thanks.
फौरन बड़ी हो जाएगा अंदर
वो उधर तक पहुंच
फौरन बड़ी हो जाएगा यही दे तेरा कैथेटर ही दे इधर से मैं लगाऊंगी फिर तू फ्लश करना उसको
Dr. Hetal,
yes madam
we just want to, are you doing that right now?
Yes, I'm trying everything to get rid of it. They
Okay.
have taken a catheter halfway inside, taking it right till there.
Yeah. Doing
Sir?
a suction? You're trying a suction?
I have put an oxygen catheter there.
Okay, okay.
I put it through the suction,
Ah,
but my problem is that I don't have a 90-degree suction here.
right.
I know that with 90, when I feed it, it will come out.
But the catheter is going through the suction and touching?
Yeah.
It's not.
No. Till they. It is so badly stuck, it's just not coming out after the wash also.
Yeah.
Suction. Curate the 90 degree.
Try lifting it near the base on one
Madam, I
side.
can't. I have tried every instrument in the OT to reach there. See, it's reaching only till then, just falling short of a millimeter.
Right, right. Yeah, I can see that.
And I don't have in this direction the suction.
No, no. What about the upward? The Henkels, upward Henkels?
Madam, I'm in the frontal.
No, I know.
So even the frontal forceps are not reaching there because the posterior wall.
And the flush is also not working.
Because flush is not going in that direction. Something has to go 90 degree.
Yeah. Flush from behind instead of front and see.
I tried even that. Asha, do me one thing. Give me a red 90 blade. 120 blade दे दो. उससे flush करेंगे. There's one blade which will reach there. Yeah, give me that. It will go there. 100%. Go there, go there, go there.
I think you're touching it, are you?
Yeah,
Yeah.
this is a 120 red blade. Section लगा उसका. Divider
Even-
लगा दे. देख
It
मुंह
seems
तो
to
हुआ.
have loosened. It's loosened, I think. It's dropped. Got something.
Something has come out.
Yeah.
एक काम कर, इसको section लगा दे and I will manage that. Yeah, blade बाहर निकाल और उसको section लगा दे. See, it has come, something has just,
Something has dropped, I think.
yeah.
अभी वो 90 डिग्री क्यूरेट पे आ जाएगा.
Now the flush may work, yeah. Yeah.
जसं दिसतं तसं नसतं. कार्तिक, वो ब्लेड को ये लगा दे. Section लगा दे and I'll flush it. ये सब बाहर निकल खराब हो जाएगा.
Irritating also.
सलाइन section लगा. सलाइन लगा, सलाइन अटैच होएगा. नहीं होएगा. चल जाने दे. ऐसे ही दिखते हैं.
They have not yet started. They waited. They showed it.
हाँ?
So they were draping the
पहुंचता किधर 90 पे है क्या?
till they're draping to switch over.
चल अभी वॉश देते हैं. अभी हो जाएगा.
Abhi. I keep showing the balls. We keep showing the balls all the time.
Now only wash. Sir, flush.
There.
Finally, successful mission. Can you see?
Yeah, yeah.
Cleared up. Okay.
Yeah, fine.
Very well
Thank you
done.
very much.
Thank you very much. So we're switching now.
Yeah, yeah.
Could they switch to the other OT, please?
Yes, please. आता काही नाही आता बस झाला वर्ड एनएस एनएस वापरतात मी कधी मला एनएस नको चेंज कर दूं अभी डाल दूं मेरे स्कूल दोनों बाजू पे एक बाजू डबल को सेक्शन छोटा वाला देना
Could we have the other OT, please?
ऑडियो विजुअल
Somebody has to call from there.
चल निकला तो सही एटलीस्ट
वहां से बोलना. Yes, to call.
Hello, Arvind, just shift to another OT.